Good morning to you and welcome to our NTV live talk show. This morning, whilst multilateral funding for HIV and AIDS is dramatically increasing from 2004 to 2008, it has largely plateaued in the last 8 years. Across sub-Saharan Africa, up to 20% of total spending on health is used for HIV services, and of this, over 85% is estimated to come from international funding rather than in-country sources. In Uganda alone, the physical liability to maintain services for all those who are currently receiving it is estimated to be much as 3% of the gross domestic product. Now, current access to HIV care, inclusive, free of point of delivery provided by the Ministry of Health, as well as out-of-pocket financing and health insurance provided care at private for or not for profit facilities. We do have the HIV response being funded through the Ugandan Ministry of Health, and also regarding the national budget allocations, as well as the multi-international dominations that also providing us funding, for example, the PEPFAR project, as well as Global Fund, among other international funders. However, it is very, very critical and of a major concern that our current funding mechanism for HIV programs here in Uganda is difficult to sustain, and it begs the question why. That's why you do have the Uganda AIDS Commission that is keen to explore ways in which we can provide lifelong HIV care as to many people living with HIV AIDS as possible through sustainable HIV financing. So welcome to NTV's talk show on financing for national HIV response, powered by the Uganda AIDS Commission in partnership with the Ministry of Health. I am Priscilla Regina Naloga, and as I introduce my guests, the hashtag to use on this conversation is hashtag #EndAIDS2030UG. Now, allow me to introduce my guests. From my immediate left, I do have Dr. Augustine Lubanga, who's the National Medical Director, AIDS Healthcare Foundation, Uganda Cares. That's how it's commonly known among communities. Good morning, Doctor, and you're most welcome.
Thank you. Good morning, Priscilla and viewers.
Okay.
Nice to be here for this discussion.
It's a pleasure to have you. We also do have Dr. Vincent Wagambe, who's the Director of Planning and Strategic Information with the Uganda AIDS Commission. Good morning to you, Dr. Wagambe.
Thank you very much, Priscilla. Our dear viewers, good morning to you, and happy to be here.
Okay, so let's start with the Uganda AIDS Commission. I know that you have committed yourself to end transmissions by 2030 for RCA in Uganda. We have about 7 years to that, 6 years now that we're coming to the end of 2023. And so, Mr. Bagambe, in line with that direction and in line of recent news that have come out that new infections are now more prevalent in the youth, how do we merge that gap by 2030?
Thank you very much. And you are right. We have just 7 years to the end of 2030, and we have that goal of ending AIDS, which was pronounced by none other than His Excellency the President of the Republic of Uganda. And where are we now? We have 1,400,000 people living with HIV in Uganda. We are seeing about 51,000 new HIV infections each year. And we have been able to identify, diagnose, and put on treatment 90% of the people living with HIV and AIDS. And the good news is that when we put them on treatment, 94% become virally suppressed, which means that they are living healthy lives, they are able to go about their routine work, and therefore contribute to the national economy, be productive, and support their families and communities. But we have a challenge that we still see new HIV infections. I've said the number is now around 51,000 per year, whereas we can say we have progressed because it used to be twice that 10 years ago. But in real terms, that is still a high number. And unfortunately, that number is among young girls. It's among young people, 15 to 24 years. And when you even deep dive in that age group, adolescent girls and young women are the most affected. So for us to move to the to our goal of ending AIDS by 2030, first and foremost, we must end new HIV infections. We must see that our young people and even the old ones who are getting newly infected with HIV, that process is curtailed. And of course, then we must also make sure that the people who are on treatment, the 90%, continue getting their medication. They are consistently taking their medication, what we call being adherent. They adhere to their medication. And if they do that, then we will see fewer and fewer deaths or AIDS-related sicknesses. So when we say we want to end AIDS, actually it doesn't mean that we will have 0 people living with HIV and AIDS. We'll still be having people in Uganda, maybe who are 5 years, some of them even 60 years, but they are living with HIV, they are taking their medication, and therefore they are healthy. But we want to see 0 new HIV infections. We want to see 0 AIDS-related deaths. We want to see 0 stigma and discrimination that relates to HIV and AIDS.
Okay. You made the relation to 10 years ago, this number could have been over 100,000 people. Dr. Luvanga, we are now looking at 51,000 new infections per year. That's a great milestone. How has financing actually helped Uganda reach this milestone in dealing with the scourge of HIV and AIDS?
Yeah, thank you very much, Priscilla. Financing is key. There's no epidemic like HIV that you can fight without having policies and commitment to continue financing to fight the epidemic. So we see that in 2010, the time is talking about more than a decade ago, when the new HIV infection were ranging in 100,000+ new cases. What enabled the country is actually to push or to commit, and we see just in the financial year 2015-2016, government upped up its even domestic funding to go from $33 million to about $76 million in financial year 2019-2020. So and even the funding from our donors, the development partners, that also went up, and we are able to fund first of all the primary prevention interventions, but there has been also some kind of change in the focus to focus more on treatment and the supportive area of it, and ignoring some of the what we know actually has helped us to fight the epidemic, like the traditional ABC, the condom programming, things to do with the testing, and so there has been a neglect on that, and probably that could be the reason why we are having the new infections coming. So we are coming in to remind ourselves and tell the stakeholders that we should keep the promise, and we should have continued funding to enable us, and even focus it well on those interventions that can help us win. We know that treatment helps. It's a game changer in this. But also, as he mentioned, there are those 5-6% of those who are on treatment who don't benefit from it. We still have those who are not yet identified and then linked into what? Linked into care. So the other traditional methods of primary prevention and what are still key, and they need our continued funding to see that we optimize the benefits.
All right, I do agree with you. The ABCs need to also continuously be funded so that they aid in the fight against HIV/AIDS. In having this dialogue, as we look into financing for national HIV response, we are also joined by Dr. Sarah Hanakwa, who is the head resource mobilization with the Uganda AIDS Commission. Good morning to you, Doctor. You're most welcome.
Good morning, Priscilla, and thank you so much for having me here.
It's a pleasure to have you. Now, in regards to resource mobilization, if you were to give us a spectrum of the last 10 years, how has resource mobilization aided in the work of the Uganda AIDS Commission, especially as far as people living with HIV and AIDS is concerned?
All right, thank you so much, Priscilla, and I'm glad I'm here and you've hosted us here today. We must say that the struggle continues. We had thought we seeing the tunnel just so close, but we are coming at a situation where priorities are now just too many. And when we say the priorities are too many, it doesn't mean funding for HIV has actually gone down, but because the envelope that HIV was getting has so many other priorities. So meaning you have the same amount of resources coming from the government, you have the same amount of resources coming from the globe, but problems are more to cover that. So it has been a very challenging situation now, but over time, we must say that HIV has had a very fair share in terms of financing. We have had, right now, when you look at the National AIDS Spending Assessment, on an annual basis, we spend over $600 million for HIV. And of course, that is way too much, you know. But of course, that does not mean there is a lot for HIV. The HIV problem has big expenses. When you go into the detail of knowing how much is spent for what, treatment alone, for instance, to have a person on treatment for a year, we spend close to $600,000 per person. And then when you're talking about how many people can we afford as a country to pay for HIV, the biggest problem here is as the numbers increase, every day you hear a number increasing, just count that as 600,000 on the envelope of the government of Uganda. So the question is, are we able to afford that? So monies have been there, but the challenges are growing and the problem is still with us. And that's why when we are talking to ourselves as a country, do we think for the 40 years we have had the problem of HIV, the friends out there from America, from Europe and all that have been helping us, do we think they can still sustain that help? Obviously it's not. So it's not that people are going away, either because they don't want Uganda or what, but the problems are too many. And so they have to share that cake because we are having so many other children. For instance, young children now are getting cancers and all other problems. So this effort goes to so many other non-communicable diseases beyond HIV. So we must say that there has been a lot of contribution and a lot of effort to fund the response, but time comes and we get to know that we need to do more than what we are going to do.
Okay, Dr. Hanakwa, can you tally for us, with the funding that has been received so far, what are the achieved milestones that we can tick off and say in the year 2023, this has been achievable as far as funding is concerned for HIV/AIDS?
Okay, so we must say that we have at least achieved 70% of the required. Between 70 and 65, between 65 and 75. But you see, this 30% that has not been achieved is leaving someone out there getting an HIV infection. So you would rather ensure that you have adequate resources. And for us, the big portion, because we want to say this 70% achieved or 60% achieved, who is contributing to it? When you go look at the statistics, the big majority, over 80% of the resources are coming from our friends outside Uganda, America, Europe, and all that. And then, of course, there's been a lot of effort from the government. But you know that the government funds a lot to do with infrastructure, like hospitals and treatments and so forth. So I can ask you, Priscilla, what has been your contribution, you as a person? And this is what we are talking about. And if you hear this year's theme, it's saying that HIV is my responsibility. And when we say our responsibility, or my responsibility, we are not saying our. We're very, very very focused when we're saying my responsibility, because then you, Priscilla, you will say my responsibility, and Miss Sarah will say my responsibility. And the responsibility here requires us to finance, but also prevent. So everyone's responsibility requires you to identify the area you're going to do.
Okay. Dr. Bagambe, why should we be talking about sustainable financing for HIV as a country?
First and foremost, the reality is that we have people living with HIV and AIDS. We have 1.4 million Ugandans living with HIV and AIDS. They deserve services. They deserve to be cared for by government and by the people of Uganda. Secondly, we are still seeing new infections, and as Sarah said, we are already constrained. We can't afford to continue seeing new HIV infections coming on board, and therefore further constraining the resource envelope. So, and then the other factor that we can't lose sight of, and Sarah also somehow mentioned it, is that when you look at the horizon, the global financing horizon, it's been flatlining for Uganda. And I can tell you Uganda has been lucky, because for other countries, it's already going down. So if we have Ugandans that need services, we have our friends who have been giving us resources, and the indication is that this might reduce. I think the best thing, the fair thing for us to do as a country is to make sure that we start looking at sustainability of these services. How do we do it as Ugandans? How do we do it at institutional level? Ministry of Health, the other government institutions. How do you incorporate a thing or two in your program to ensure that as a whole, wholesomely as Uganda, we are able to sustain the services for HIV? I think for me, we have to start looking at interventions that actually reduce new HIV infections. We have said we have 90% of people living with HIV on treatment, but if we continue getting new HIV infections, it means that that percentage keeps reducing, but also the need that we will have to cover keeps widening. So we need to now focus on interventions that cross the top and reduce or eliminate completely new HIV infections. And these include communicating to the people, especially the young people who are not like me, Vincent, who lived in the times when Fire Rutaya was communicating his messages. And I was able to see people live who were suffering from HIV and they had AIDS. The young people don't have that experience. And so we have to intensify sensitization so that they appreciate the fact that we still have, HIV is still a problem, it is still there. And that they can do something, they can take responsibility for their lives to ensure that they don't acquire HIV and AIDS. Government has put in place commodities for HIV prevention. We have HIV circumcision services. We have condoms. There are programs where, for example, a child or a young person has been raped, a case of rape, discordance relationships, where they can go and access services for pre-exposure prophylaxis, and so on and so forth. So we want really to emphasize to the people that it is their responsibility to access these services and make sure that they contribute to not having many new infections.
Okay, all right. Dr. Lubanga, in regards to that, we do commend the work that is being done by organizations such as yourself, the foundation. The Uganda Cares Project has really been enormous in supporting HIV, preventing new infections, but also getting these services closer to people living with HIV/AIDS. However, most recently, the Daily Monitor put out a very interesting report stating that because of existence of these services and the sensitization that he has talked about, that has been very good on the side of government, on the commission side, and on CSO's side, people no longer fear to get HIV/AIDS. So how are we going to deal with the new infections if people no longer fear HIV/AIDS?
Yeah, the issue of complacence, I mean, that attitude of saying, after all, there is treatment, HIV is not as dangerous as diabetes, which kills you within a few years, just in case you've not taken the medication. They are there, and we hear the population commenting on that. But I think, as the Dr. Bagan put it, it's more of communication. I think we have not, there's some literacy gap when it comes to the population. We have new entrants in the population.
Yes.
And some of these measures actually were stopped. I think there was some agreement that where should we put the little money we have, and part of that was put more in care and treatment, neglecting the other things. But I think with the new young people that we have, we need to see that these messages continue and reach them. So good enough, we now have a package for passing on this information to the population. But again, still expensive. We need money to reach out to the media, but also use the current technology that can target these groups. You can no longer go with the drama and these other things. You need to go smarter, and these need funding so that that awareness is created. Once the people are educated, but I think we do believe that they'll be able to prevent, but also take on the services that we have.
Okay.
Yeah.
In your capacity, why else should we be focusing mainly on HIV prevention? And away from the resources that you've talked about, what other alternatives do we have towards that?
Yeah, the alternative, I'm saying that first of all, we are in a better position than before. We have time-proven approaches, things to do with like testing and linking these people to care and treatment. We have things like a condom promotion that have been proven to work, and that combined with the new tools. For instance, he talked about the medication given to those who have been exposed and so on. We have safe medical circumcision, all these to our advantage, and others that have been recently discovered. So these are with us amidst the big challenge that we have of the 52,000 new HIV infections that we are having. So what we need to do is that we need to see that these are scaled up to reach each and everyone. Of course, going smarter and so on. But there has been some kind of them being not well funded. Yeah, they are not that well funded and so on. So the interventions are there. We just need to ensure that our commitment to financing them is actually there where it deserves to be.
Okay. On that note, I would like to then intervene and ask, since on the international funders side, the envelope is reducing, the funding is reducing, and Dr. Bagambe said, so far Uganda is still lucky. I'll come back to him and ask what have been the things that have made us lucky, because they don't just give it to you. You must be doing something to respond to that money coming your direction. So on a ground level and on a national level and even localized level, how do we then create a sustainable funding and financing for HIV?
How to create that? Of course, there have been several demands. He talked about you as a person, your responsibility. We know that if you keep yourself HIV negative, there is a contribution that you are making. The 600,000 that is required to treat a positive case every year, you will have saved the country in that respect. There was also a thinking that should we look in those areas probably that are kind of looked at as risk areas, but also where Ugandans can show their contribution, like the AIDS Trust Fund has been some of the things. But I think we came to a state of saying that probably there is fatigue continuing pursuing it, and they know we need to change the focus and things like that to that. But avenues for domestic would include things like even insurance towards that, but how many people are on insurance and what? So now we are left with a government who is taking the role of treating and ensuring that Ugandans are healthy through the mainstream funding for health. Okay. And yeah, we are reminded that as a country, we are signatories to the Abuja Declaration, where we had pledged to have.
We are signatories, 15, but yes, it has not yet matured for Uganda. Why?
It has not.
That 15% that is supposed to be towards health is already being divided with other ministries and other needs or priorities. Why are we failing to arrive at that 15%? I believe it would then answer the sustainable financing Dr. Bagambe is advocating for.
Sure, why we are failing, but I think if you make a commitment, then you should. And in the investment plan that we have as a country, we said, okay, 15 may be too much. Let's go with the 10%. But looking at the previous years, it has been averaging about 8%, sometimes even going below. But we see that in nominal terms, in terms of billions, that money has been going up. But as a percentage of the national share, what it makes, because that has stagnated, hasn't gone. And once you don't have that money committed and provided to Ministry of Health, then there is no way HIV and the other services will be adequately funded. There are those schools of thought that health is beyond even infrastructure development, security and so on contribute to that. But I think this was a well thought process, and saying that yeah, there are those specific health interventions that need to be well addressed and targeted for us even to realize benefits in the other sectors that we need to fund. Yeah.
Dr. Hanakwa, in regards to assessment of the national budgetary allocations towards HIV, in most recent financial years, they have actually been suppressed, which I believe makes the work for the Commission very, very hard. Are there any engagements with the Ministry of Health that are happening to revise those allocations and increase them, I guess, within the next 7 years to help the Commission achieve the zero infections 2030?
Okay. Thank you. And maybe say engagement with the Ministry of Finance, because they're the ones who are here. So true. Like where I started from, I said no one doesn't want to fund HIV. But the beginning point is we have more priorities right now than before. And every year we see things coming on board. Whoever knew that we're going to have COVID? And then when it came, all the resources around HIV were pulled there.
So you've mentioned the word priority again. So what are those that are being considered priority right now?
So priority, because now we are dealing with poverty, for instance, as a country. You know, all efforts are running around that as a country. But back to HIV, we are seeing a situation where, yes, we are not saying that we are off the hook. We are not funding HIV per se. But we are looking at what can actually sustain our response. And it's not that because we have been heavily relying on donor support, that when donors reduce, then we sit back. As a country, we have had a lot of engagement, both with the Ministry of Finance and the private sector. I could actually go direct to that. That there's been effort to say that the private sector is a critical partner in the HIV response. Why? Because the private sector will always be here. They are always here and have been here. And the private sector is an entity that reaches everyone's household. And we are saying, what can we leverage on their expertise, for instance? What does HIV require? And what does the private sector do to have the HIV space, you know, move within the private sector? And we're saying that for them as critical partners right now, what is in the HIV response for the private sector? So you see that we have moved away from, because we know that we are working with the limited envelope as the country, so we are just not focused on domestic resources from the government per se, but we are putting on board the private sector and looking at what opportunities we have within the private sector. I can mention one, that when we're talking about the private sector, we are not necessarily asking for the money direct, because then it goes into another discussion. But the private sector, like say NTV alone, is very good at communication. That communication can be quantified. It's very expensive. But NTV alone providing that information through their mainstream can become cheaper if they come on board. So they will not have given you money, direct money, but they have used their space to reach out to many people. That yes. When we talk about which product is very common, everyone knows Coca-Cola, for instance. Priscilla, Coca-Cola reaches every part of this country as a bottle. Even a baby knows a Coca-Cola bottle. Every household knows a Coca-Cola bottle. How does that Coca-Cola bottle reach that household? Oh, Mukwano, let me talk about Mukwano. Every household gets a soap of Bao Mukwano. How does the Bao of Mukwano reach this household? But the same household doesn't have a condom, yet they need it. The same household needs ARVs, but they can't access it because it's far. You get what I mean?
Yes.
So what we are talking about is how do we leverage on the business expertise that the private sector has, and we partner such that we use their chain supply management approach, their communication approach, their marketing approach, because HIV is about marketing and telling people to understand the problem, to reduce the infection that my colleagues have just talked about. And then we use that. You realize that this country will be remaining with one major effort to look out for money for, and that is treatment. For those who are HIV positive, we have to make sure that there is drugs in the hospital and they get it. But when it comes to prevention, everyone should be able to get a condom. Everyone should be able to get information at a no much cost. Probably, we say, when you're moving a Coca-Cola bottle to a particular supplier or agent, move along with the condoms. So you enter into partnership with the government, Ministry of Health, and Coca-Cola, meaning that all Coca-Cola agents will be trained to store condoms, to be distributing the condoms, and so forth. And this is where we need to go, because we just don't want to say that we need more money, but what avenues, what resources are already existing
can we tap into?
That we can tap into, and this is what we're talking about.
All right.
So the private sector needs to come on board and see what expertise, what space do they have for this discussion. We shall have reduced the big cost of paying everyone to go and distribute condoms, paying everyone to go and communicate, paying everyone to go and sensitize the community. The cost of human resource.
And, all right, Dr. Bagambe, let's look at some of the models that do currently exist. One of them is out-of-pocket financing. You do have the health insurance, but also you do have what government is offering at the public service health centers, that free medication, if you can call it, testing and medication treatments. In your assessment, are those aiding the financing burden?
Yes, they are aiding the financing burden, because when you look at the annual expenditure on the HIV response, the domestic contribution has been increasing. When we first did a national aid spending assessment, I think that was 2008, 9, 10, thereabout. Clearly, we were spending the contribution from the domestic sources, government, private sector, and out of pocket, the individual contributions, was going to about 11%. This has been increasing. We've just done another assessment, and the preliminary results show that we are moving to about 14%.
Okay.
So we think that the domestic efforts are beginning to bear fruit, but we still need to do more. We think that if, for example, the national health insurance comes on board, the bill has been passed, but once it becomes operationalized, it will also pick up some of the costs for the HIV response, perhaps laboratory tests, perhaps maybe the other medications, not necessarily ARVs, and all those, and perhaps also paying off some of the health workers. And all those will reduce on what we need to sustain the response. I think government has committed to contribute over, so each year they make an incremental contribution of 50 billion Uganda shillings. And so that 50 billion Uganda shillings, of course, is about 15 million US dollars. So when you compare it with the total requirement of 600 million Uganda shillings that Sarah talked about earlier, we see that progressively will also be reducing on this. But I think the other factor that we shouldn't forget is the leveraging on the already existing services. A person who is living with HIV and AIDS, but also has pressure, hypertension or diabetes, we need now to see how to integrate those so that this person is able to come only once, is seen by one health worker, but receives both the services. The same applies to this woman who is HIV positive, but wants to have family planning, medication, or other sexual and reproductive health services. These can also be offered together and reduce the burden on the recipient, the client, but also the workload of the health facility, and therefore ultimately the cost of offering these two separate services.
Okay, in that regard, how do we then strengthen the healthcare system in Uganda to be able to do the dual support to HIV response being a priority, but also to cater to the other health-related challenges that these people and population could be having?
And I think we have started that journey, only that, of course, we started with the higher facilities. If you go to the regional referral hospitals, you'll find that this patient can benefit from all these services in one go. That although there is a clinic for a diabetic clinic in the regional referral hospital, there is an HIV clinic, but for these clients, these services have been merged into one. I think what is needed is to make sure that this integration is scaled down to the district hospitals, to the health center 4s, up to the health center 3s, which are easily accessed by everybody in the country. So what it requires, of course, is capacity building of the existing health workers, but also to ensure that the health facilities in those, the starting points, health center 3s, are well staffed for the health workers, the existing health workers, to be able to offer that integrated service.
Okay. Dr. Lubanga, in that regard then, on a national level, what could be stopping us, especially on the side of policy?
On the side of policy, actually, what is letting us down is what I would say is inadequate, but also unfocused investment for these simple things that my colleagues have talked about. Yes, although you say that we are not yet there to have the 15–10% funding, but what can be done? Yeah, a lot needs to be done. The issue of prioritization comes in with limited resources, but also we don't use that just to say we are comparing the others who have probably gone a mile ahead of us, and but we need more funding because we have models, modelings. For instance, if we are to get this kind of performance, what do we need? And it all tells us that we need more what? We need more money to come in.
Okay.
But even with the little that we have, we see that how is this appropriated for the various HIV interventions and things like that? Yeah, we see that there is a bit of leaving out the prevention or primary prevention aspects of this. So we need to ensure that more money comes in, but it's not as money being brought in. There are other areas of for us to gain efficiency, as my colleague has talked about, integrating these services, but also not only in space can we have providers who are trained and they are 360 in providing all this, but even the infrastructure per se. There are some models that have tried to integrate all this. You just come, walk in, and then either you're HIV negative or positive, you are all following the same line. So how do we have these and what? But it will require us to get that level of zero stigma and so on.
Okay. So dealing with specialization to make it a one-stop center health system for all to benefit concurrently. Okay, Dr. Hanakwa, in regards to private sector, are there any current programs that are being run and funded or supported by the private sector, as well as people living with HIV/AIDS and communities in regards to financing the HIV response?
Thank you, Priscilla. Just to have it as a sport is everyone is playing their part. And the private sector is being a fair game player here. Like they have really tried and they're still continuing to find ways of trying. Clearly, to your question, I can highlight a few things that are going on and probably the public to really appreciate when especially the private sector gets to them. We have recently had a program called $1 Initiative. I don't know if you have come across it, but this $1 initiative, I think we even want to change it to remove the dollar and make it shilling, 1 shilling initiative, but 1 shilling, I don't know. I don't know whether 1 shilling or maybe 1,000 shillings. But at that time, we're looking at if a dollar was about 3,000. So we're saying, really in this day and life, if every adult of Uganda pays 3,000 shillings as a private entity, for a year, by the way, not even a month, for a whole year, how much is that? And then the private sector looked at that as an opportunity because they would really talk to Priscilla to pay 3,000, to Vincent pay 3,000. In the end of the day, using the multiplier effect, that 3,000 is a lot if you're just targeting about 15 million people in Uganda. And we wanted to understand how Ugandans respond to such calls. You know, we sit back this way and we think Americans, Europeans should pay our bill of HIV. It's high time we get to know that we are actually going to pay for this bill, we like it or not. So, starting with 3,000, each of us here, seated even in the studio, can pay for a year. And then we said, okay, $1 initiative, the private sector ran it, and for the first year, it was very interesting. Everyone was very actively involved. I don't know whether you paid your part, Priscilla, but people paid 3,000, which was $1 then. The year 2, year 3, people lost interest. So we shall come back and understand the public. What do they say about this $1 initiative? That was a very big, by the way, we may want to say that this is the only initiative in the whole world. And people, actually, the UN country, I mean the UN executive director then came to launch it. It was all over the media and people flew in here to ask how we are doing it. So of course other countries probably are even making it, designing it better, and we shall also go to them and learn from them. Benchmark, but those are the initiatives we have. Uganda is very, very proud of the initiatives that start with us here. So if we can only run with that. Then when you talked about The other initiative we have from, again, the private sector. That's what I'm saying. Private sector is really up in the game. Most of the hotels, we went into an arrangement with them. So in the hotels, Priscilla, just putting these condoms that the country is procuring in the drawer is a contribution. You see, we aren't talking about people giving us money, but contributing within your space. And so when you open, I don't know how often you use the hotels, but when you open the drawers, there should be condoms. And so as a guest for that hotel, if you don't see condoms, actually be the responsibility person to ask why aren't the condoms in here. Even if you're alone, you don't have to be with probably going to use them. So the hotels are actually doing that. They put, not at a cost, you know. Otherwise, you'd have found people paid for to distribute that. Then we have had also some hotels giving space, venue. If you're going to do anything to do with HIV work, they actually don't charge you for venue, but you just buy food or drinks that you're going to use. So do you imagine how much in the whole total hotels, you know, everywhere hotels are having conferences, workshops and meetings. So you'll see how much that is being contributed by the hotels. They have not come in to give money directly, but their space is money. And so they have said, use that, but you can buy a meal as you're sitting. So you pay for the meal, but you not pay for the venue. So when we change all that into into actual monies, that's a lot of contribution from the private sector. And we are saying these things are, in fact, they are manageable. We can achieve this, such that HIV remains a problem that is for everyone, and you contribute based on where you can contribute. And coming to the community, like you said, the HIV, people living with HIV as a community, Priscilla, it's very expensive to pay a counselor, for instance, a counselor, and so that counselor you have to pay. But you see, people living with HIV, they call themselves peer counselors. So they provide that information at no cost, but they're counseling themselves, relieving the cost that would have been to recruit such. So there are so many opportunities out there.
Okay, so I know whoever is in the private sector watching this program this morning, you have realized exactly how you can contribute without really breaking an arm and a leg or having to sit in so many meetings to allocate budgets. But in your own space, you can contribute to financing the HIV response. So speaking of contributions, Dr. Bagambe, I know that the Uganda AIDS Commission is also making their fair contribution. There's a National AIDS and HIV and AIDS Symposium kicking off tomorrow. Please give us more information on that.
Yes, Uganda AIDS Commission was established actually to coordinate all the actors in the national HIV response. So all the stakeholders, what they do, whatever contribution they make in their own way, our business as Uganda AIDS Commission is to make sure that they are doing it and that they are doing those interventions that we prioritized in our strategic plan. Every year, we convene all the stakeholders to take stock of how much has been achieved in this country. So for this year, we have decided that we will do it in a symposium, the National HIV and AIDS Symposium. We did the same actually last year. We were at MUBS, Makerere University Business School. This year, we are doing the same. We are going to have a 3-day event. It will be opened by the Honorable Minister for the Presidency tomorrow. And the venue for this event is the Millennium Park, which is next to Uma Showground. So we invite all of you to come. We'll be having activities that relate to that show the interventions or the services that are offered in Uganda. We'll be having scientists also making presentations of the up-to-date and the breakthrough science that the research is proving to be effective. We'll be having young people also sharing their experiences, young people living with HIV and AIDS, but also young people who are HIV negative but they are also making an effort to remain HIV negative. We will have musicians also making, playing their music as a way of preventing HIV and AIDS. We will be having exhibitors showing all sorts of and categories of the HIV services that are offered in Uganda.
All right.
So it's a 3-day event. Feel free to come. It is open to all of us, free of charge. Come and be part of this important activity.
Okay, well, thank you so much, Dr. Vincent Bagambe. He's the Director of Planning and Strategic Information with the Uganda AIDS Commission. We've also had the 2 cents and advocacy of Dr. Sarah Hanako, Head Resource Mobilization, still with the Uganda AIDS Commission, advocating for private sector to come in partnership against HIV/AIDS new infections by 2030. And of course, Dr. Augustine Rubanga, National Medical Director with AIDS Healthcare Foundation, also commonly known as Uganda Cares, has given us his 5 cents on the matter, and we're very grateful for having had this discussion. In conclusion, it is of great concern that the current funding mechanism for HIV programs in Uganda is not sustainable, and as those that are in the commission, service providers, CSOs, they must have a keen way to explore new ways, new financial avenues in which to provide lifelong HIV care to as many people living with HIV/AIDS as possible in Uganda. And so in reality, it is likely that only a model that combines several different financing approaches will provide the necessary care and treatment for people living with HIV/AIDS in the future, until such a time as the Ugandan economy can support that fully and finance the HIV response. State-supported comprehensive healthcare bridging alternatives must be continuously considered, and those were shared earlier on in our discussion. Therefore, in 2023, as we mark the 35th commemoration of World AIDS Day with the theme World AIDS Day 35, Remember and Commit, we speak to the government, the civil society organizations, and the private sector to remember and recommit. Thank you very much for having been a part of this program. I am Priscilla Regina Nalwoga.